Drug overdoses. This is one of my most fun talks, so you'll have to bear with me. So again, I don't have any financial relationships, but I will talk about some off-label uses of drugs. I'll try to point those out. We don't have a lot of evidence-based medicine when it comes to toxicology, so that's why these are not agents that go to the FDA for approval in many circumstances. So when we're talking about a poisoned patient in the ICU, there's certainly a lot of steps that we can go through. Obviously, stabilization, resuscitation. We're going to talk primarily a little bit about diagnosis, a little bit about GI decontamination, then we'll go through some specific toxins and talk about interventions and antidotes that you might need to know about. Keep in mind that underlying all of this is good supportive ICU care, which we're not going to delve into because you do this every day. Now, when it comes to diagnosis, it'd be great if they had a sign that says, I took 50 tablets of X drug. And that's not the way they present. And even when they tell you what they took, about half the time it's incorrect. So what you really would like to know is the substance and the quantity. But the other thing you want to know is the time of ingestion. Did they take it 30 minutes ago? You have a long time for potential toxicity to develop. Did they take it 5 hours ago? And maybe the risk of toxicity is now over. The other thing is it a sustained release or a regular release drug? Now, sustained release drugs are probably great for our patient compliance. They're terrible with toxicology because you have ongoing absorption. So it's very important to try to elucidate this so that you can anticipate problems. The other thing you'd like to know, is this a single acute ingestion of a drug they've never seen before, or are they toxic on a drug they've been taking chronically? In general, there is more toxicity involved with chronic users of drugs than that single acute ingestion. Now, on the physical exam, you're going to do a complete physical, as we're always told to do, but I will tell you with toxicology, you want to concentrate on your vital signs and your neurologic examination when you're trying to determine what they might be exposed to, because you'll see patterns, things that increase blood pressure, increase heart rate, increase the temperature will fall into the sympathomimetics, the anticholinergic drugs. On the opposite side, things that lower blood pressure, heart rate, temperature will be your narcotics, antihypertensives, or the sedative hypnotics. For the neurologic exam, the level of consciousness, again, falls into the agitated and depressed. Again, groups of drugs, sympathomimetics, anticholinergics, agitation, narcotics, sedatives, that depressed level of consciousness. Pupillary size, big pupils, sympathomimetics, anticholinergics. Remember, meperidine is the narcotic that can give you dilated pupils, so there is that exception. Small pupils, narcotics usually. Now, you have to be careful because if it's a mixed ingestion, you may not really have pupils reflect the drugs they've been exposed to. Seizures are another clue. Many of the sympathomimetics and the anticholinergic drugs will end up causing seizures. Now, our practice for GI decontamination has really changed in the last 10 years. Epicac is no longer recommended for adults or for children. Cathartics are not recommended. The theory here was that we're pushing things through the GI tract and it's not absorbed. Never been shown to be effective, so we don't need to do that. Gastric lavage is really going out of favor. We have no proof of efficacy, and the recommendations currently are that you may consider using it in a life-threatening ingestion that occurs within 1 hour of presentation. Most of our patients don't present within 1 hour. So, and again, I'm not telling you should do it. Even in those circumstances, there are significant complications that can arise, such as esophageal perforation. And unfortunately, I've seen 2 of those in my career, and I really don't want to see any more. Now, whole bowel irrigation, nobody's quite sure what to do with this. This is basically giving a electrolyte solution that you use for bowel cleansing, and you pour it in 100 to 200 mLs per hour from the top until it looks the same going out the bottom end. I will tell you, nursing staff will not appreciate this if you do it. Okay, they will not like you. The theory is, again, pushing drugs through the GI tract before they're absorbed. It's been suggested that perhaps for sustained release drugs, illicit drug packets that are drugs not absorbed by charcoal, such as iron and lithium. but we don't have any evidence of efficacy, and volunteer studies have shown that it really doesn't move everything through. So it's very unusual to see this used. Activated charcoal is the most common intervention for GI decontamination, but even its use is going down. Activated charcoal, to be of benefit, should be administered within 1 to 2 hours of ingestion of a toxin or a drug. Many times our patients don't get to us fast enough. So again, we're actually kind of leaning away from many of these techniques that we did in the past. Now, the other way to get rid of drugs is to use our normal hepatic or renal mechanisms to excrete drugs, and that's where multiple doses of charcoal come in. Basically, it's using the intrahepatic circulation of drugs, the excretion, again, of metabolites to kind of capture them in the lumen of the gut. There's also a concept of GI dialysis, just the gradient between the blood and the intraluminal component and just pulling drug across. We used to use this quite a bit for a lot of things, but currently the evidence would suggest it may be of benefit with barbiturates. We don't see that in the U.S. Theophylline, we don't see that in the U.S. Maybe carbamazepine, you may come across that. And I've never seen a dapsone or a quinine ingestion, so very limited use. Forced diuresis, forget it, doesn't work. May get you into trouble if you do this too vigorously with volume overload. Alkaline diuresis does work. It will enhance excretion of two classes of drugs, salicylates and barbiturates. Obviously, the one that we would most likely see would be salicylates. But you have to get the urine pH up to 7, and that's a little difficult to do at times. Now, for some of the life-threatening ingestions, hemoperfusion or hemodialysis are used. Now, I know in many institutions they don't even have the charcoal hemoperfusion cartridges anymore, but don't worry too much about it, because everything that can be removed with hemoperfusion will have some clearance with hemodialysis. In the unstable patient, you can think about the continuous dialysis techniques, but since our experience is better with traditional intermittent hemodialysis, that's probably the way to go. The one exception might be with lithium intoxications. Okay, so which one of the following poisonings would potentially be most lethal? Methamphetamine, fluoxetine, ethanol, acetaminophen, or oxycodone? Okay, good. You recognize that, acetaminophen. It's very important. This is just some data from the DAWN network, which compiles data from selected emergency departments, and they look at a lot of things, but they look at deaths from poisoning. You'll see the top category is a pretty broad one, sedative hypnotics and antipsychotics. But what's interesting is cardiovascular drugs have moved up from the bottom to near the top, and that reflects the availability of these medications in homes. But then the next one is acetaminophen, either alone or in combination. And this is, again, theoretically a preventable death. Antidepressants are going down the list, and we're always going to have the opioids, the stimulants, and street drugs on this list. So let's start with acetaminophen. One thing to do is always consider that it might be a co-ingestant. Unintentional overdoses now are estimated to be over 50% of those that cause liver failure. And what this means is that patients are usually taking more than one acetaminophen-containing product, and it's usually a narcotic acetaminophen combination, and then they take acetaminophen on top of that. And it's often inadvertent. They don't realize the danger, and this is really becoming a problem in this country. The maximum daily dose that's recommended has now been lowered to 3 grams instead of 4, but you have to keep in mind also an assessment of risk. So people at higher risk, chronic alcoholics, the malnourished, which is our elderly, and then certain drugs, there's many drugs actually that induce the CYP450 enzymes. Now, charcoal is effective in absorbing acetaminophen if the patient presents early. You want to get the acetaminophen level at least 4 hours after ingestion, because you're going to compare that to the Rumac-Matthew nomogram. Between 0 and 4 hours, there is no line, so please don't get one earlier than that. It just confuses people. But there's another limitation here. The Rumac-Matthew nomogram is to be used only in single acute ingestions presenting within 24 hours. Okay? Now we're getting these chronic users of acetaminophen, people who take multiple doses or multiple overdoses over a period of time. You can't use the Rumac-Matthew nomogram. So there is that limitation. And we'll go through how we're going to do that. We're going to use our transaminases and the acetaminophen level to determine how we're going to manage those people. And of course, you want to assess for hepatotoxicity in these individuals. You know the antidote. It's either oral or IV in acetylcysteine. There's advantages and disadvantages of either form. Obviously, the oral stinks, and people tend to vomit. But one of the concerns now with the IV regimen is that it may be too short. So in massive overdoses, the recommendation is now to think about continuing treatment. The most important thing to remember is that you want to get N-acetylcysteine started within 8 hours of ingestion. If you do, the chance of any hepatotoxicity is slim, especially any significant liver failure. So again, many people will say check an acetaminophen level before you complete the IV course to make sure you have reduction in that acetaminophen level. And if need be, you might check with your poison control center as well at that point. Now, what about those chronic ingesters? Those that present after 24 hours or they've done multiple overdoses. Well, here, basically, if an AST or ALT is greater than 50, you treat them with a course of N-acetylcysteine. If there's any acetaminophen level at all in these patients, you treat them. Obviously, fulminant hepatic failure gets treated if it's thought to be due to acetaminophen. Now, I want to talk about metabolic acidosis, and I just want to point out on the list of the agents that cause metabolic acidosis is acetaminophen. It has actually been shown to cause profound acidosis. These are usually massive overdoses. Metabolic acidosis in toxicology is really bad, okay? That's a bad sign for these patients. Now, typically we associate often the metabolic acidosis in toxicology with our other alcohols, such as ethylene glycol and methanol, which we're going to talk about. But everything on this list is a potential culprit when you see that. Now, ethylene glycol and methanol are pretty lethal ingestions. Hopefully they don't inject it, but and the clinical findings are such that you can't really differentiate these. You may have patterns within your area. In Houston, we see ethylene glycol. Other areas, you may see methanol, but they present the same. Now, I have to tell you a caution about the metabolic findings. The classic is the osmolar gap and the anion gap. You have another slide there on your set that shows the metabolic pathway, so be very careful. Often these present late, and they will not have an osmolar gap because the alcohol has been metabolized to acids. If they present really early, or if they actually also have ethanol on board, they may have an osmolar gap and no acids. So the classic findings aren't always exactly what you see. What's also interesting is that you may see an increase in lactate, and that's due to interference with the assay. There are some clues if you need to distinguish which agent you're dealing with. Oxalate crystals, although they may give you this as a clue to this type of ingestion, that's ethylene glycol. Visual disturbances, if they describe that to you, is the hallmark of methanol ingestions. Now, if you also look at the metabolic pathways here, it also helps us understand why we do the things we do as a, quote, antidotes. So our goal is to prevent the alcohol being metabolized to acid. We can inhibit the alcohol dehydrogenase. What we previously always used was ethanol. We could give that IV or oral. It was always a kind of everybody running around trying to figure out concentrations and how much to give. What we do primarily now is use fomepizole. It's a competitive inhibitor of alcohol dehydrogenase. It's given as a bolus every 12 hours, and it blocks that metabolism. It's much easier to use. It was very expensive. It has now gone generic, if you will, so it's less expensive. Some people have reported using fomepizole alone without dialysis, and I would caution you about this. The situation where they have described this is if you have a patient who has absolutely no acidosis and no renal dysfunction. But again, I'd be very cautious about trying to use fomepizole alone. Dialysis is often needed to remove not only alcohol, but the acid metabolites. And the indications are a level, and if you can get a level back in a few hours, let me know, because it takes usually 3 days. So basically, it's clinical suspicion and the presence of an acidosis. You dialyze these patients, and it's high flux dialysis, and it's prolonged dialysis. Mortality in these ingestions ranges from 30 to 50%. So you do have to act very aggressively with these individuals. Other therapies to consider: folinic acid enhances methanol metabolite excretion. They're often alcoholics, so thiamine, folate, glucose may be needed. In the past, we used to give a lot of bicarbonate for the acidosis. That really doesn't help a lot. It can get into trouble with volume overload, so it may be temporizing until you can get dialysis started. But the key here is inhibiting with fomepizole and dialysis. Now, another alcohol I just want to point out, because I think this is fair game for a board exam, is propylene glycol. That's most typically seen toxicity with infusions of lorazepam at high dose for more than 3 days. And that's because it's the diluent for lorazepam. It is also the diluent for nitroglycerin, phenytoin, and phenobarbital. And cases of patients that have been on lorazepam and phenobarbital have developed propylene glycol toxicity. You get an anion gap and an osmolar gap. The problem is you can get agitation, and what do people do? They turn up the lorazepam, but you can get seizures, arrhythmias, hemolysis with this. So basically, you have to stop lorazepam or any other drug that has propylene glycol in it. If you need sedation, you have to use another agent. Midazolam will work. Diazepam, no. That's also propylene glycol. And it is dialyzable, but usually you don't have to proceed to dialysis to manage this type of toxicity. Benzodiazepines. We're kind of a stressed nation, so the most common benzodiazepine in overdoses is alprazolam. But we also see clonazepam and lorazepam. Particularly, these are often part of the triad of drug abuse. They use a narcotic, benzodiazepine, and carisoprodol or soma. So we have an antidote, which is flumazenil. However, we don't use this very much in toxicology. And if the patient needs airway protection, we advise intubating these individuals. The problem with flumazenil is a very short half-life. So if you wake someone up, you may walk away, and the next thing is they're hypoxic or they're aspirating. The other problem is that there is a risk for seizures, particularly in individuals who have taken cyclic antidepressants or in chronic users of benzodiazepines. And I will almost guarantee you 100% of the time anyone overdosing on a benzodiazepine has chronically been taking benzos. So you don't want to run the risk of precipitating withdrawal and seizures in that patient, because you've just saturated all of their benzodiazepine receptors, and it's going to be difficult to control the seizures. All right, next you have a 25-year-old woman presenting after ingesting unknown pills. She's lethargic with pulse of 62 and a blood pressure of 86/40, and you have an EKG tracing there. The question is, which of the following is the best initial intervention? Transthoracic pacing, lipid emulsion, glucagon and calcium, or dopamine? Okay, good. Glucagon and calcium is the answer. And we'll go over lipid emulsion since that came up a little earlier as well. So bradycardia, when you see it, the key here is bradycardia and hypotension. So bradycardia in toxicology, here's the list. We don't see some of these very often. The most common are going to be beta blockers, calcium channel blockers, but don't forget about clonidine, because that can also cause a significant bradycardia. Digoxin as well, but we don't see as much digoxin being used today as we did in the past. So do you need to figure out if it's beta blocker or calcium channel blocker? It'd be nice if you know, but you can use a similar approach for both. Glucagon is the antidote for a beta blocker overdose. The hypotension in beta blockers, and actually also in calcium channel blockers, is more a function of the negative inotropic effects than the bradycardia. So what you need is an inotrope and a beta blocker. Glucagon is an inotropic agent. It doesn't require a beta receptor. So that's more effective in beta blockers overdoses, but it's also been found to be anecdotally helpful in some calcium channel blocker overdoses. Calcium would be the next thing. If you know it's a calcium channel blocker overdose, you use calcium. If that doesn't work, you can try glucagon. Pacing, you might get someone's heart rate up, but you may not see a change in the blood pressure. So that's not usually going to be the method that you're going to choose. People give atropine, it doesn't work. So don't waste your time. Dopamine, epinephrine, all of the catecholamines have very variable responses. Now, one intervention that is being promoted, particularly for calcium channel blockers, is high-dose insulin. And insulin turns out to be an inotropic agent. And, of course, to prevent hypoglycemia, you give glucose. Now, the range of insulin doses is fairly broad. You can tell 1 to 10 units per kilo per hour. The most commonly used has been 1 unit per kilo per hour. So it is high-dose insulin. And then we come to lipid emulsion, which has been anecdotally used, but let's just go over where the role is of lipid emulsion right now. Potentially, it has benefit with lipophilic cardiotoxic drugs. It's part of the anesthetic-induced arrest algorithm that you'll see in anesthesia literature. The case reports, and that's all it is at this point, you'll see cardiovascular agents, cocaine, antipsychotics, organophosphates. The theory is that it kind of sequesters drug or that it affects mitochondrial utilization and metabolism of these drugs. And so we don't know the mechanism. We don't know if it's really effective. The dose, again, we don't know the most effective, but the most commonly used is 1.5 mLs per kilogram as a bolus dose. It is not recommended as a first-line treatment for anything. So if you're going to use it, it should be after more routine interventions in refractory cases. There are potential complications. The more case reports, the more complications are coming up. Pancreatitis, ARDS. The other thing is the lipemia interferes with your testing. So it interferes with your CBC and your electrolytes. So at least be aware of that if you are going to use it. You can't count on those values when you see them. Let's talk about cocaine. The good news is cocaine use has been going down in this country. Now, of course, it's being replaced by other drugs, which we'll talk about as well. But we still see this. So cardiovascular toxicity is one of the most problematic. We don't see too many of the arrhythmias, the lethal ones, because they don't make it to the hospital. But what we do see is acute coronary syndromes, which is the most common presentation in emergency departments. Now, I still like to show this case. This was a 28-year-old, came into our ICU with hyperthermia, rhabdo, renal dysfunction. He was intubated. Classic EKG is just sinus tachycardia in these individuals. This was his EKG 3 days into his hospital course. He's still intubated. You can see the ST elevations here, also loss of all his precordial electrical activity. So he had his MI 3 days in after his use of cocaine. And the point is that you can't assume that it's going to happen right after use. It's been described, these ischemic events, up to 2 weeks after the last use of cocaine. So you may have a patient that's there for a cholecystectomy routinely and develops an MI, and it might be because they were using cocaine. This is not necessarily a young person's problem. We see this in 50, 60, 70, and 80-year-olds. We have a guy with EF less than 20%. He's 50 years old. He comes in with cocaine abuse quite frequently. So what do? You can treat them similar to other acute coronary syndromes. Aspirin is given because cocaine causes platelet aggregation. If they're agitated, benzodiazepines are probably the first line of treatment. If they have ongoing chest pains, you can give nitroglycerin. Often they don't have ongoing pain at the time they come in. For sustained hypertension, you can consider calcium channel blockers, but beta blockers have also been used. Now, you can say, well, I can't do that. It's unopposed alpha forces. But we're not talking about that patient. We're talking about the one who has an indication after those acute sympathomimetic manifestations have subsided, and they do subside fairly quickly. These people often have other risk factors for coronary artery disease. Cocaine itself can accelerate atherosclerosis, so they would be candidates for any of the traditional reperfusion techniques. Well, of course, the brain suffers, seizures being the most common with cocaine, and of course, probably the worst is intracranial bleeds, either parenchymal, similar to our hypertensive bleeds, or subarachnoid hemorrhage. What we know is that these people have worse outcomes, and they often rebleed more if they have a subarachnoid hemorrhage. That's probably not surprising. We know they can have strokes. This is due to cerebral vasoconstriction as well as thrombosis. Often the question comes up, who do I screen for drug use when they come in with strokes? And I thought this study was interesting, and it probably brings home the point. Up to almost 20% of people with stroke under the age of 50 are positive for cocaine, but if you look at those over 50, it's 9%, so 10%. So I would say it wouldn't hurt to screen your individuals, because obviously you need to have other interventions on the social front as well. Now, other cocaine toxicities, we don't see much in the way of pulmonary problems anymore because the product is so pure that's marketed out there. What is problematic sometimes is intestinal ischemia and infarction. And this can appear acutely or kind of chronic, kind of subacute pain. And they get these little segments of the small and large bowel that get infarcted. And it's very difficult sometimes to decide whether the surgeon should go in. Obviously, renal failure and rhabdomyolysis. Renal failure is not always due to rhabdo. There are also direct effects of cocaine on the renal vasculature that probably play a role. Hyperthermia, we just had one of these cases in our ICU, cocaine user in our heat. The other thing is levamisole contamination, or any contaminant. Levamisole has been the more common one in the U.S. recently, and it causes first of all, it causes neutropenia, or leukopenia, and it also can present with a thrombotic kind of vasculopathy that's particularly the nose and the ears. So if you ever see that, you might think about whether they're using cocaine. It is reversible if they stop using the cocaine. Treatment, a lot of work going on for antidotes, but there isn't one yet. For the agitation, it's benzodiazepines and more benzodiazepines. You might consider haloperidol if benzos don't get you the effect you need, but you have to be careful because it lowers the seizure threshold, and obviously cocaine does the same thing. The main thing is to think about all these potential complications and seek them out and treat them with standard therapy. So very similar to cocaine is amphetamines and methamphetamines, and this has taken over some of the market from cocaine. They can be inhaled, they can be snorted, taken orally, injected IV. And we always associate this with the big labs that are still out there, but there's now kind of easier ways to do this, and it's called shake and bake to make methamphetamines. And basically, they can do this with smaller quantities of pseudoephedrine that now are restricted, alkaline batteries and everything, and they put it in 2-liter bottles, and it has to be vented correctly or these things will explode. So there's actually another whole field now at looking at explosive injuries from methamphetamine, these small-time manufacturers. The complications are very similar to cocaine, with the exception of cardiomyopathy. These drugs are longer in duration, so that catecholamine impact on the heart stays longer than cocaine. And we just had, again, another gentleman in our ICU with an EF less than 20% who was an amphetamine user. So it's not as common, but these people presenting with these cardiomyopathies, you might want to go back and ask, were they doing any of these drugs in the past? This is an interesting website. It gives you a lot of information about illicit drugs on the market. Interestingly, it has personal testimonials, too. They've taken the recipes down years ago. But it also has linked to the medical literature, so it's interesting. They have a glossary of terms, so if you don't want to look like an uncool person, if somebody says, well, I did AMP or I did FRI, you can go and look it up and go, yeah, I know what that is. So it is an interesting website. It is helpful, I will say. What do we do? Again, we don't do gastric emptying because it's usually absorbed by the time they get to you. So really, you'll find a pattern here of these sympathomimetic drugs. We use benzodiazepines, supportive care, and anticipating the complications. Okay, 24-year-old admitted to the ICU for seizures, hyperthermia, tachycardia, and agitation. Drug use is suspected, but the urine toxicology is negative for phencyclidine, cocaine, and amphetamines. Which of the following is the most likely toxin? Ketamine, LSD, mephedrone, or gamma-hydroxybutyrate? Okay, this was a hard one. This is methadone. This is bath salts. Anybody heard of bath salts? Seen these patients? They're kind of interesting. So bath salts can be, it's a combination. Methadone is one of the components, pyrovalerone. These are derivatives from the cat plant, which is grown in East Africa. They chew the leaves just like the coca leaves. It's hard to import this stuff, so they just started manufacturing it in the lab. And these drugs are both a stimulant and hallucinogen. They look like any other drug. They're these white powder crystalline stuff. They snort this, they inject it, they inhale it. The hallmark here, it is the sympathomimetic effects, but they have very marked paranoia and very aggressive behavior. This has resulted in homicides, suicides, and you talk about needing benzodiazepines. These guys need more than what we usually use in our cocaine abusers. So it's very impressive if you see these individuals. So they're no different. The management just requires more restraints and more benzodiazepines. Now, the other drug this could have been in that described patient is a synthetic marijuana. You would think if it's a marijuana, it would lead to mellow effects, but not these agents. They bind to the cannabinoid receptors in the brain and spinal cord. The most popular name for this is spice, or K2. This actually was started in Europe, in Germany, and came in our direction. There was a place called Psychedeli in London that made exorbitant profits from this before it was outlawed. The attraction for many people to use these, it's not detected in drug screens. So you can't pick it up. These are some of the things. This was one of our patients. This is Climax Potpourri by Kush. That's a big marketer of these products. On the back, it says it's not to be smoked, not for human consumption, and not for anybody 18 years or younger. Yeah, right. Now, you can also go on the internet and you can get, what is it, Blue Dream Kush. It's blueberry herb flavor. It's got 5-star rating for returning customers. So, you know it must be good. That's legalbuds.com. But this, you can find. Now, many of these compounds have been outlawed. The problem is if they change one side chain, one little thing, and they can go back out there and market it. This is one of the changes, is the internet marketing of these other drugs. And these are all called EPS, emerging psychoactive substances, and they have really been a real terror to control in this country and other countries. The synthetic marijuanas, you'll see the manifestations again. The sympathomimetic effects. One of the things that's interesting, and I just found this recently, we haven't seen it in our patients, is that they can get hypoxemia and may not show up well, but this has kind of got some ground glass looking there, interstitial look, and on CT scan they can have what's evidence of organizing pneumonia with these drugs. So again, the management here is sedation and supportive care. The renal injury is kind of unique here. This is the drug that's really been associated with more renal failure than some of the others. And we have seen this in our patients. They actually may go out with permanent renal failure on dialysis. So, and it's not all due to the rhabdo. There's something else that's associated with that, because the rhabdo actually may be mild in many of these patients. Okay, 30-year-old woman with a history of depression presents with altered mental status and the EKG below. Hopefully you can see that. And the question is, which one of the following interventions is indicated for the arrhythmia? Amiodarone, cardioversion, magnesium sulfate, or sodium bicarbonate? Okay, good. Sodium bicarbonate is the answer. So the clue here, if you get a scenario such as this, history of depression, you have a wide, complex tachycardia. So sodium bicarb is probably good for just about any wide, complex tachycardia in the field of toxicology, or at least we have anecdotes here. So this is typical of cyclic antidepressants, but I want to caution you that it can be seen with any antidepressant, and there are more of the newer antidepressants out there now than the cyclic antidepressants. It is potentially life-threatening. This is where you might consider lavage if they present it really early. Again, I don't encourage you to do that. If they have evidence of cardiac toxicity, what we do is we give bicarbonate. What we always thought we were doing is alkalinizing the blood, changing the pH, changing binding of the free drug. But what we're also doing, and it's probably more important, is sodium loading. These compounds block sodium-potassium channels in the myocardium, so when we give sodium bicarb, that sodium helps overcome that blockade. That's why in refractory cases, there are anecdotal reports of hypertonic saline being helpful. Now, this is also where you might consider lipid emulsion if they are refractory to the bicarbonate. So this is one instance where you would consider that. These patients, if they're hypotensive, you want a direct alpha agonist, and obviously if they seize, it's benzodiazepines. Any drug-induced seizure, it's benzodiazepines. I wanted to mention hypoglycemic agents because we have so many out there now. We have so many diabetics. Often when we see hypoglycemia, we give glucose, or we may give glucagon to release glycogen stores if they have glycogen stores. But all of those interventions actually increase insulin secretion from the pancreas. So the one intervention that doesn't do that is octreotide. So in our type 2 diabetics who are on sulfonylureas, if they're coming in hypoglycemic, I encourage you to try octreotide. It decreases insulin secretion. Okay? Even sulfonylureas increase insulin secretion from the pancreas. So it's 50 to 100 micrograms every 8 hours. You can give it sub-Q or IV, and what it does is it inhibits the insulin release, so you have fewer hypoglycemic episodes, and it shortens the period of hypoglycemia. So you don't have that up and down hills and valleys that you see when you're giving concentrated glucoses. The other caveat to remember with our long-acting insulins now, particularly in our elderly or anybody with renal insufficiency, the episodes of hypoglycemia may last for days. Narcotics. This is a growing exposures and growing deaths in our country, and it has been the prescription narcotics mainly because we have pain centers and they like to advertise very well. We had drive-through pain centers in Houston, in Harris County. They obviously use these drugs orally. They crush them and inject them. They snort them, with oxycodone and hydrocodone being the most commonly diverted. It's very interesting how interventions change the pattern. Buprenorphine has been used for detoxification, and now it's also being diverted as an abuse drug. And also the problem is we have these sustained release drugs now that have these prolonged effects. But I wanted to also mention heroin, because with the federal regulations being tightened, evidently the supply has decreased for oxycodone and hydrocodone, so people are going more and more to heroin. Heroin deaths in a 2-year period in 28 states doubled, okay, doubled. And that's between 2010 and 2012. So heroin is going up. It's coming out of Mexico and South America. The other concern is fentanyl. In 2014, there were over 3,000 deaths due to fentanyl. In 2013, there was 940. These are being produced in underground labs, and there's also compounds called acetylfentanyl that are being found. And again, as you know, these are very potent drugs, so it's not surprising that the deaths go with them. You know the antidote to naloxone. Just remember, you can give it a variety of ways: IV, IM, endotracheally. They've also now described intranasal and nebulized. I guess that's a kinder, gentler way to give it. But the key here is that you may have to give higher doses to reverse these synthetic agents. So just because they don't respond to 0.4 or 2, you may have to go up to 10 milligrams to see if it will reverse those effects. And of course, you can use a continuous infusion to keep them awake and avoid intubation. Also, I just want to point out that we now have approval for home naloxone kits or auto-injectors. So this is being prescribed for patients with chronic pain who use narcotics. And also you can get it if you have a family member that you know is an abuser of narcotics. This has been available in Europe, and it was just recently approved, I think it's last year, for the US. I wanted to mention tramadol because tramadol is being prescribed as somehow better than narcotics. It's actually not. It's addictive. But it's interesting in that in overdose, they can present either kind of lethargic, comatose, or they can present agitated. So keep that in mind. The other thing is that it will give you a false positive for phencyclidine on the toxicology. So if you see a phencyclidine in someone that you don't think it fits, it might be tramadol that you're dealing with. Cholinergic syndrome, I mentioned this briefly because it's fair game for board exams. This is the hypersecretory syndrome, the sludge, salivation, lacrimation, urination, defecation, GI upset, and emesis. And this would be seen since associated with organophosphates and carbamates, but I could also see them giving you a scenario of a nerve gas, sarin, which this is the way that it exhibits its toxicity. The treatment, the antidote is atropine. These people die from hypoxemia, from the respiratory secretions. Intubation doesn't do away with that. You have to dry up the secretions. If you don't have enough atropine, glycopyrrolate would be another option. Most hospitals don't have enough to treat large numbers of exposed individuals. Pralidoxime helps reverse the muscle weakness. There is a caveat here. When you intubate these patients, you don't want to use succinylcholine because it will prolong that muscle weakness. So hopefully they wouldn't give you that kind of question, but it might help you take care of your patients. SSRIs, they are safer, but please keep in mind they can cause depressed level of consciousness. We just had a patient using an SSRI show up with an overdose and seizures in our ICU. They can cause arrhythmias. It's just less common. But the unique feature of these SSRIs is the serotonin syndrome. And if you look at the manifestations, it's altered mental status, it's autonomic dysfunction, neuromuscular abnormalities. They get this tremor, and it looks a little bit like neuroleptic malignant syndrome. But it's not. It's a different mechanism. This is serotonin excess. In the ICU, the most commonly reported combinations of medications is an SSRI and an opiate, and an SSRI and an antiemetic. We give those drugs, don't we? Keep in mind also linezolid and tramadol. Those can precipitate serotonin syndrome. That, I think, would be fair game for our questions. What do? Stop the agents and its supportive care. For sedation, what's been reported, I would typically use benzodiazepines, but both propofol and dexmedetomidine have been reported to be successful in sedating these patients. It'd be very unusual to need neuromuscular blockade. It usually resolves in 24 to 72 hours. Some would recommend a serotonin antagonist, such as cyproheptadine. There's very limited evidence of efficacy or even improvement in outcome, but it certainly may not hurt your patient if you wanted to try it. Herbal products. We buy billions of dollars of these products in the U.S. The ephedra alkaloids were banned in the U.S. in 2006, and they're now limiting the amount of ephedra in some of these herbal medicines in the U.S., but they precipitated sympathomimetic syndromes. People died with these things. That's why it was banned. Well, we're very entrepreneurial, so these manufacturers developed these ephedra-free supplements. Unfortunately, they have ingredients such as synephrine, octopamine. Zinedrine is one of the ones that has been associated here, and you can't always tell. It may say bitter orange, which is synephrine, but these have been associated with MIs, strokes, syncope, and even deaths. Now, how many of you have had an energy drink today? Raise your hand. Nobody? Oh, I don't believe you. See one right there. Oh, back there, our AV guys. You see how boring we are? They have to do that. Well, let me just tell you, these, you can get what a Monster, Red Bull, I don't know all these names. Very popular with young adults, but these are now more and more, we're seeing reports of arrhythmias and cardiac arrest and deaths. These drinks are probably the most common cause of atrial fibrillation in young adults in emergency departments today. And these are people who are drinking 3, 4, 5 of whatever. I don't know what you do with those little shot things. Those are how many of those count. But just be aware that this may be a problem. Even caffeine tablets will do this, and that's also been described. These are two websites, herbmed.org, and then the Memorial Sloan Kettering Cancer Center has a complementary medicine section that's very good if you want to look up some of these things. Those are good resources. Now, I'll just close with what I call my hospital-acquired intoxications. The government hasn't found out about this yet, so hopefully they won't. But we do intoxicate our patients occasionally. Gabapentin. Somebody comes in on gabapentin and their renal function worsens and nobody notices. They go to sleep. They become comatose. And you have to be careful about this. The maximum dose for someone with end-stage renal disease is 300 milligrams a day. We had a patient come in on 900 milligrams a day, and he was not talking to us. Narcotic overdoses. This is a real problem, that need to make everybody have a nice, smiley face. Now, I don't know about you, but we're getting probably 1 to 3 a week in our ICU. They don't have to stay too long. We let them wake up. Hand sanitizers. Purell is everywhere, okay? These are 60% ethanol or isopropyl alcohol. So alcoholics, where there's a will, there's a way, they will ingest these. So if somebody gets intoxicated in the hospital, think about this possibility. We talked about methemoglobinemia. This is one of the cases. This was a TEE. You can see the blue patient and the pink. That was my fingers, I think. And the methemoglobin level was 30%. We've talked about propylene glycol due to lorazepam infusion. And the last thing I want to just cover is propofol infusion syndrome, because I think that would be a potential for a board exam question. We're using more propofol since we're trying to decrease benzodiazepines, but there are potential problems here. Who's at risk? If you look at this list, sepsis, impaired oxygen delivery, head injury, that's a lot of our patients, isn't it? Anyone on high doses for prolonged periods of time. It was reported to be more common in surgical patients, even at low doses. We've had a young woman who overdosed on something else, and they sedated her overnight, intubated on propofol, and she actually had a lactic acidosis by morning. So the hallmarks of potential toxicity, myocardial failure, so if they're on pressors, you're having to go up on the pressors, that's a clue. Arrhythmias, lactic acidosis. If you see the lactate go up and you don't think they're septic, think about propofol. You can get rhabdo, renal failure, hyperlipemia. That's clearly an indication. We actually do follow their triglycerides now on people on high doses and also check the lactate every now and then. But this can kill people. It's very high mortality rate if it's not recognized and you don't stop the infusion. So I'll stop there, and thank you very much.